let's move on to the very first question.
Okay.
So from Poi, may I know how to reduce knee pain, especially at the kneecap area when cycling and jogging?
Okay, so anterior knee pain, which is where the kneecap area is, can be a result of many different things. It can be a cartilage injury. It can also be the fact that your muscles may not be very strong, and therefore the patella, your kneecap, may not actually be moving in the proper way, in a proper manner, and I think to be able to avoid doing or making the situation worse, is actually important to find out why you are having that pain. And a doctor should be able, maybe a GP, should be able to assist you in doing at least a preliminary assessment of what's wrong with your knee. And if it is something structural and something which is serious, he might actually refer you to a orthopedic surgeon. But the usual situations are, of course, to rest, not to overstrain it if it's a problem of overstrain, to treat it with some painkillers if basically it is you have already overstrained it and there's a little bit of inflammation going on. Sometimes painkillers and rest actually just does the job wonderfully. Physiotherapists can help you if you are doing something wrong, like if you are jumping and you're landing in a wrong manner, or if you have got an area of your muscles which are weak, they are able to target those things. And of course, if it's structural, if it's a structural problem, like there's a cartilage injury, there's a cartilage hole there, then you probably need help of an orthopedic surgeon to help address this condition. Yeah.
Thank you so much, Dr. Chan. Okay, next question from Anonymous. Is the meniscus posterior horn tear repairable?
Yes, it is. In fact, the posterior horn or posterior root tears have always been very difficult to repair because of the very small space that is present in the area. But the meniscus is a very interesting structure because it's anchored on the two ends, the front and the back. They call it the horns or the roots. And when those areas get truncated or they get cut off, the whole meniscus is called what we term as defunction. It means that it's no longer be able to cushion the load because it kind of moves out of place every time you put a lot of weight on it. The repair of it most often involves putting a suture around the suture is a string, putting a string through that part, and if it is near the root or right at the end of the meniscus, we have to drill a hole through the bone and anchor that bit which is torn into the bone. Today there are a lot of new instruments that allow us to do this fairly easily and with actually minimal injury to the cartilage surrounding the area. Yeah, so more and more you do see people who have got root repairs actually having it repaired. Yes. Oh, sorry, root injuries having it repaired, not root. Yeah. Okay.
Okay, next up from Gary Lowe. So what would you recommend for flat feet runners? Because he tried using insoles, but it didn't really help him.
Okay. Well, flat feet is a fairly common thing. So there are two kinds of flat feet. One of them is a rigid flat foot, whereby your foot doesn't change in shape even when you tiptoe. That usually means there's something structurally wrong with the bones, the way that some of the bones are actually fused or attached to each other and they are not actually able to move. So the foot structure itself is fixed in one position. If that's the case, it's a more serious type of flat foot. So the more serious type of flat foot would then require some form of surgery for it to be done, for it to be treated. Yeah. The other kind, which is the more common ones, are the flexible flat feet, and the flexible flat feet is sometimes the result of ligaments being a little bit more lax or the muscles being a little bit more lax. Now, using an insole certainly helps in putting in the correct position, but insoles are not the only thing. You probably need to strengthen the muscles around as well, and the physiotherapist will actually be able to help in strengthening some of these important muscles like the tibialis posterior tendon, which is very important in holding up the medial arch. So that is one of the muscles that people tend to strengthen, and of course you can see if certain shoe wear can help you as well. For people who have flat feet, they tend to pronate. Pronate meaning that the medial arch tends to press down a lot. So there are certain shoes which are made such that we correct overpronation when you're walking and you're running, and that helps in terms of your symptoms. Yeah.
Okay, we've got two questions about osteoarthritis. The first one is, are there any supplements that you can recommend for knee pain? And also from Facebook Live, we've got one from Nasir. Is past ACL reconstruction injury a cause of osteoarthritis for old age?
Okay, so let me take the first one very quickly. Supplements are actually not medication. So for supplements, you can actually make a whole lot of claims in terms of the effectiveness, and to some people it may actually work, and to others it doesn't. But the criteria, the standard of making such claims for supplements are not as stringent as if it is a medication. If it's a drug, then if you say that it helps for a certain thing, you need to prove it with a scientific study. So for supplements, as I said, sometimes it helps a certain group of people, sometimes it doesn't. It doesn't mean that it has got no use, but it is a bit more difficult to recommend supplements because the effect may not be as predictable, or we cannot quantify it, or doctor cannot tell you that, okay, it is very likely that after taking this, you get this benefit. For osteoarthritis, some of the common supplements people use are things like fish oil with omega supplements, glucosamine, which has been used for quite a while, and of course, there's one more, which is collagen. Yeah, so some of my patients take this with very good effects, and I encourage them to continue taking it. But I also tell people who are starting off, if you take it and it doesn't help you, or you don't feel as though it's helping you after 3 months or so, then you don't really have to continue taking it, because yeah, I mean, it's a supplement, yeah, and not a medication. Okay, the second one is does a previous ACL injury cause or previous ACL reconstruction, does it cause osteoarthritis? Did I get the question correct?
Reconstruction, yes.
Yeah, okay. So maybe another way of seeing it is that a previous ACL reconstruction does not prevent osteoarthritis. What I'm trying to say is that if you had injured your knee, although we are able to replace the anterior cruciate ligament, we cannot restore it completely. The function is not completely restored to what you were born with. Secondly, as you injure your knee, you might not only just injure your ACL, you might injure other parts of your knee as well. And those things may have a long-term effect after months or years, like a bone bruise. A bone bruise is when the bone bangs against another bone and there's an area of injury within the bone itself. Now, there is fairly common that you see some bone bruises in patients who have got ACL injuries. And in fact, the pop that most people hear when they have an ACL injury is not because the ligament snapped, but because the bone was hitting against another bone. And that pop is the contusion that you are actually feeling or you're hearing. Those things may actually result in cartilage injury over a period of time or a longer period of time that may not be present at the point when the ACL is reconstructed. So if you compare a knee which has got an ACL injury and reconstruction done versus the other knee, if it had not had any injuries before, even if you had an ACL reconstruction on the knee that you had injured, it would still tend to degenerate or to get osteoarthritis earlier than the knee which has not been injured before.
Thank you so much, Dr. Sean. Okay, we've got another anonymous question about ACL reconstruction. So they said I had an ACL reconstruction last April and was cleared to play competitive ice hockey after 6 months. Should I be concerned about the other tears shown on the MRI? There was a partial MCL tear and menicocapsular separation. I was told this can be managed via physiotherapy, but I'd like your opinion.
Okay, so MCL, a partial MCL tear tends to scar down quite predictably. The MCL is pretty vascular, and so it tends to be able to heal if it's not a complete third degree tear. Even if it's a complete third degree tear, it does heal, but it heals not with the full, it has got a little bit of laxity that is remaining behind, but most people are still able to continue in their games. I had previous rugby players who have got a full tear of the MCL, and they were still able to return back to rugby. So I think the MCL injury may not be something that is too worrying. The meniscocapsular separation, it depends on how big the separation is. Usually a small one in the back of your knee, because it is in the area where it's very vascular. The meniscus and the capsule is right at the periphery where there's a lot of blood supply. It tends to be able to scar, and it tends to be able to stabilize itself fairly okay if it's not a very large meniscal capsular separation. If it's a very large one, then of course it's more predictable if it is repaired. I'm sure that was properly assessed when you were doing your surgery. So if the surgeon and the physiotherapist have cleared you to play ice hockey, I think you can go ahead and do that.
Great. Okay, we've got one more from Joan Lim. So she said, hi, I wonder what happens when they hear a crackle sound at both knees, but it's painless when they bend.
Okay. So sometimes these clicks and pops happen to people. It's much like when you crack your knuckles. As long as it's not actually causing discomfort, it may be fairly normal to get some clicks and pops. It can also be the result of a tendon or something going over a bony prominence that causes a click and a pop. The main thing that I would want to assess if a patient complains of clicks and pops is whether or not you feel any jamming of your knee. If you feel that when you are walking and a click is associated with you unable to fully straighten your leg, you feel like something is getting stuck in your knee, then that is something which is a little bit more worrying. Or if you have got swelling of your knee, frequent swelling of your knee as a result of this clicks and crackles and all, then it could also mean that the cartilage is not smooth and there is cartilage injury. So it's not taken by itself, but it's taken together with a whole other bunch of symptoms if you do have them or not. And usually an orthopedic surgeon or a doctor will start asking you a bit more questions with regards to your concerns.
Okay, we've got one from MF Sia. He wants to know what what do you think about PRP? How effective is it, and do you need to frequently repeat this?
Okay, so this is a new form of treatment, which I think over the last maybe 7 to 10 years has become more and more popular. The PRP involves drawing out blood and then spinning it down, concentrating your platelets. That's why it's called platelet-rich, and then it's injected back to the area where it's injured. Now, these platelets tend to contain growth factors which degranulate when they are injected back to the area. So there's a higher concentration of these growth factors, which is supposed to stimulate healing. It has been shown to have good results in certain indications, like if you have got a Achilles tendon tear and the tear is being surgically repaired, putting PRP in that area actually does tend to help it. And for things like acute muscle tears or ligament okay, sorry, not ligament injury, the soft tissue, yeah, ligament and tendon injuries. If you inject it in the area and you're not operating on it, it has been shown to actually improve those symptoms. So those are the actually two things which the Ministry of Health had approved for its use. Beyond that, things like injecting it into the joint, injecting it into, I mean, it's been used for a lot of other things which can be described as off-label, which means that people are kind of using it in terms of saying that the theory behind it is sound, but we don't really have enough evidence yet for it to be able to be used in a widespread manner. Yeah, for these other off-label users, I think we need to practice a little bit of caution, and you need to understand what you're doing for it. And one of the things that is actually a worry, or rather a concern, is that in the market today there isn't a standardized version of what a PRP is, which means that how much platelets there are within the preparation for different kinds of different preparations can vary. So if you use one particular company's manner of preparing it, you can end up with a different amount of platelets within the injection that you're going to give versus another company. Yeah, the amount of blood that you draw is also different. So there are a lot of these variables which have not actually been standardized yet, and because of that, it is a bit difficult to look at all the studies which have been conducted and make enough sense of it, because it's not really comparing apples to apples, or it's not having a proper baseline to compare these things with. So as I mentioned, those two things earlier, the operative repair of the Achilles tendon using PRP to augment, as well as injuries to ligaments and tendons which you're not operating on, they are accepted as a good form of treatment, but the rest we are still trying to get more information on it. Now it is relatively safe because you are actually injecting what you draw off your body back into yourself. So that's why I think a lot of people find it okay to go ahead doing it. And there are some studies which do show that injecting into a knee, for example, does help in symptoms. So if you understand the reason why it's not a widespread thing, that it's being accepted by everybody, and you understand the theory behind what we're trying to do with it, and you are okay to go ahead after understanding the risks, expectations, and complications of the procedure, then yes, I think it's a fair treatment to be offered.
Okay, so Yen Kwek has asked, may I know what's the criteria that doctors look into for allograft or autograft when there's ruptured ACL? So they've got more specific, they've got more specific thing. May I know the reason why the doctor recommended conservative treatment instead of surgery for a 75% meniscus tear for an active basketball player aged 14 years old?
Okay, so both questions require a bit of explanation. Yeah, ACL reconstruction with allograft and autograft. Autograft meaning your own body's graft, and allograft meaning someone else's graft, are both accepted means of treatment. They both come with advantages and disadvantages. Autograft, of course, is from your body, so incorporation is fast. It is there's no rejection. It is not expensive. It's free. You're taking from your body and putting it back to your body, and there are several studies that show that the results of using autograft are actually better than using an allograft in terms of the laxity, as well as in terms of re-rupture rate. But these findings may not be applicable to everybody, because a lot of it depends on what kind of activities that you do. Like, for example, if you put in an allograft for a person who may not be extremely active, and they are pretty careful of what they are doing with the knee, then of course the risk of re-rupture may not be as high either. Yeah, so the allograft offers what what we call no donor site morbidity, which means that you do not sacrifice any part of your body to repair another part of your body. You get it from somebody else. You maintain your own ligaments. You maintain your own grafts so that it doesn't further injure more parts of your body. You can actually select a graft of a particular size that you want. If you use your own grafts and you harvest your hamstrings, for example, you're stuck with whatever size that you have. But if you use somebody else's graft, you can ahead of time tell the implant rep or the graft, the person bringing the graft, that you want a particular size, and that may actually benefit people who may be a bit larger, and usually have got a requirement for a bigger graft. And then the third thing is, of course, for revision cases, usually you don't want to further get grafts from your own body or from another area, so you can use someone else's graft as a very good alternative. In general, I find that in my patient pool, at least, they do fairly well with both the allograft and the autograft. I've reconstructed, meaning I've done a revision reconstruction for some of the very high demand athletes or high demand professional soldiers using an allograft, someone else's graft, and they are still able to do their work just as well. So I believe that it's not such a straightforward answer. It really depends on what you think you're going to do. It also depends on whether or not you feel that you want to sacrifice any part of your body, because if you use a hamstring graft, for example, there is going to be a bit of a weakness of your hamstrings, and if you happen to be a professional sprinter, then of course that may be a problem. Of course, there are other areas that you can use the graft. You can harvest grafts by yourself, but each comes with its own morbidity problems. You call that donor site morbidity. Okay, so that's a very big area of discussion. It's one of the discussions I usually have with my patients over maybe about a 15 to 20-minute session, so that they can understand the pros and cons of why you use either of the choices. And then at the end of the day, I don't think there's a right or wrong answer. Yeah, as long as you know why you're using it and you believe in the reasons why you're using it, I think that's okay. Yeah, that's the correct answer. Yeah. So for a meniscus injury, a lot of it depends on where this tear is occurs, whether or not it's at the periphery or it's in the center, and usually I'm not too sure what 75% meniscus tear means. Does it mean that it involves 75% of the area of the meniscus, or is it that it's not a full tear, it's a partial tear, as in it doesn't tear through 100% of the meniscus tissue, it's a partial tear of maybe about only 75% of the meniscus? Because sometimes a partial tear has got, if it's a partial tear and it is at the periphery, there's a chance that it may actually scar up and it may heal by itself rather than continue to tear through. So a lot of it will have to depend on what the MRI actually shows. So, I mean, without looking at the MRI itself, it is a bit difficult to comment because yeah, I mean, if it is an unstable meniscal tear, for example, the meniscus keeps flipping in and out, I'm sure that's an indication for surgery. Yeah, but for a 75% meniscus tear, a lot of it depends on what the definition of 75% is. Is it partial tear or yeah, is it MRI is required to be reviewed? Sorry, I don't think I quite answered that question, but yeah,
it's
I would
okay.
think
I think
that,
they just need to go to you for a personal consultation.
Yeah. We'll be happy to
Okay.
provide more information after that.
Right. Okay, we've reached the end of the Q&A. I'm so sorry if we didn't answer your question, but don't worry. We will ask Dr. Sean them separately and then release them as videos on our own MCA channels. So please make sure to follow. We have YouTube, Facebook, and Instagram, whichever one you prefer. Just follow us right there now. And also, before we end, if you'd like to arrange an appointment with Dr. Sean, just drop him an email at appointment@orthokinetics.sg or WhatsApp him. And then he'll contact you shortly to arrange an appointment. So, yep, that's all we have for today. Thank you so much, Dr. Sean.
Okay, thank you very much. Thanks, Ash.
Thanks, everybody.
Okay, bye-bye.
Don't forget to like, comment, and subscribe for your regular dose of Asian health information.